Hello, everyone. I'm Megan Hall, and I'm the athletic trainer for Wilson High School. In this video, I will discuss ACL injuries, treatments, return to play following injury, and prevention programs. First, I'll start with some ACL anatomy. The ACL has two bundles that are named based on their insertion on the tibia or the shin bone. They're the anteromedial and the posterolateral bundles. The ACL originates on the medial aspect of the lateral femoral condyle. This is on the femur, which is your thigh bone. It then inserts on the tibia, which is your shin bone. In this picture, you can see how the two bundles are parallel with each other when the knee is in extension and how they cross over each other as the knee is bent to 90 degrees. The picture on the far left depicts the knee in full extension, and the picture on the far right depicts the knee at 90 degrees of flexion. The ACL's functions include providing stability to the knee joint. It does this by decreasing anterior tibial translation and internal tibial rotation, which means that it keeps your tibia from sliding too far forward away from the femur, and it limits the amount of rotation at the tibia. The ACL aids in proprioception because it has some proprioceptive receptors in some of its fibers. Proprioception is a feedback loop in the nervous system that provides the ability to sense how the body is oriented in the environment. For example, if you close your eyes, you can tell if you're walking on grass or concrete without having to look at the surface, and your body is able to adjust to walking on the different surfaces. If you have an injury or surgery, you may not notice that you have impaired proprioception. Impaired proprioception can lead to functional issues, such as feeling like you're going to lose your balance on unsteady surfaces or cause you to fall. The screw hole mechanism is a key element for knee stability. It involves the rotation between the tibia and femur and occurs between full extension and 20 degrees of knee flexion. The quadriceps muscles have a lateral pull in the late stages of knee extension. This puts passive tension on the ACL, which contributes to external rotation. This helps stabilize the knee in extension because it's resisting the anterior translation of the tibia. The ACL is a ligament, so any injury to it would be considered a sprain. Sprains are given grades 1 through 3 depending on their severity. A grade 1 sprain is mild with no significant structural injury. Grade 2 sprains have more tears than a grade 1, but the ligament is still intact. Grade 2 sprains don't occur very often. In a grade 3 sprain, the ligament has completely ruptured or torn, causing the knee joint to become unstable. ACL sprains can occur in contact and non-contact situations. Most ACL injuries occur with non-contact and are most common in athletes between 15 and 25 years old. They are typically caused by a cut and plant movement and can also occur when trying to decelerate quickly and during jump landings. Female athletes have an increased risk for ACL injuries as compared to male athletes. This is due to a wider pelvis, which causes them to have a higher Q angle. The Q angle is the angle formed between the quadriceps muscles and the patellar tendon. The Q angle is an important factor for knee function. Some signs and symptoms of an ACL injury are hearing or feeling a pop in the knee at the time of injury, pain, loss of range of motion in the knee, instability and swelling. If you have an athlete with any of these symptoms, please let your athletic trainer know. They can do an evaluation and determine the best plan of care for your athlete. To evaluate an athlete for an ACL injury, your athletic trainer will use special tests. These tests will show if there's any laxity in the joint. If there is laxity in the joint, your athletic trainer may refer your athlete to a physician to make a determination if further imaging, such as an MRI, is necessary. An MRI uses a strong magnetic field and radio waves to create a detailed image of the tissues in the body. This image can help determine the grade of an ACL injury and if there are any other injuries along with it. If your athlete has sustained a grade 3 ACL sprain or tear, they may require surgery to reconstruct the ligament. There are several options for reconstruction. These include an allograft, which is when the graft comes from a cadaver donor, or an autograft, where the graft is taken from the patient's own tissues. There are 3 different types of autografts. The bone patellar tendon bone is when a portion of the patient's patellar tendon is used to reconstruct their ACL. The semitendinosus and gracilis tendons, which are hamstring tendons, could be used as well. The quadriceps tendon can be used with or without a patellar bone block. There's not as much research on this method as compared to the other 2, and no single surgery is the best surgery. All patients and all injuries are different. If your athlete requires surgery, it's important that they are encouraged to speak with their surgeon about all available surgical options before deciding which is best for them. If your athlete has had surgery to reconstruct their ACL, they will need to complete rehabilitation prior to returning to practices and competitions. Rehab plans are broken down into phases. Each phase has goals, precautions, treatment strategies, and advancement criteria that must be met prior to moving to the next phase. For example, phase 1 of the rehabilitation plan is scheduled to last approximately 2 weeks post-op, and the goals include decreasing pain and swelling, and increasing passive knee range of motion, early progressive weight bearing, and preventing quadriceps inhibition. Precautions may include avoiding active knee extension between 40 degrees and 0 degrees, avoiding ambulation without their brace locked at 0 degrees, avoiding heat application, and avoiding prolonged standing or walking. The treatment strategies are all of the exercises the athlete will complete in this phase, along with any modalities used. The advancement criteria might be the athlete having the ability to straight leg raise without quadricep lag, having range of motion between 0 and 90 degrees, and demonstrating the ability to unilateral weight bear on the involved extremity without pain. If the athlete does not meet the advancement criteria, then they will remain in phase 1. Typically, a rehabilitation plan following an ACL reconstruction will be from 6 to 9 months. Each surgeon is different, so some rehab programs might be longer than others. Usually the surgeon will have their own rehab plan and will forward that to the athletic trainer or physical therapist. The athlete will have follow-up appointments with the physician as well to ensure that they are progressing as they should. To return to play following surgery, the athlete must be cleared by the surgeon and the athletic trainer. Once the athletic trainer receives documentation from the surgeon stating the athlete has been cleared, the athletic trainer will then put the athlete through functional testing. This ensures that the athlete has the strength and flexibility to safely complete the physical demands of their sport. The athlete should also display a lack of apprehension of re-injuring their ACL prior to returning to play. Younger athletes with a higher activity level have an increased risk of a recurrent ACL injury. A good ACL injury prevention program will include these 6 principles: age, biomechanics, compliance, dosage, feedback, and exercise variety. For age, the program should be started at an early age and correct any faulty biomechanics that put the athlete at an increased risk of ACL injury. Ensuring compliance with completing the program will decrease the incidence of ACL injuries. For dosage, frequent participation in the program will decrease the incidence of ACL injuries. Each session should be between 20 and 30 minutes and should be performed several times per week. Optimally, they should start in the preseason and continue throughout the season to attain the full effectiveness of the program. Verbal or visual feedback should be used. This can be done from the coach or with a training partner, and having a variety of exercises will decrease the risk of ACL injuries. Exercises should focus on plyometrics while focusing on proper technique and body mechanics. Neuromuscular training to improve the ability to generate optimal muscle firing patterns, increase dynamic joint stability, and to perform movement patterns and skills necessary during activities of daily living and sports activities. This may include balance exercises, proprioceptive activities on balance and wobble boards, single leg stability activities, dynamic joint stability exercises, jump training, plyometric exercises, agility drills, and sport-specific exercises. These types of proprioceptive and balance training can improve postural control and side-to-side imbalances in lower extremities. Resistance training may aid in the reduction of ACL injuries when combined with other training components. These are the references I used. If you have any questions about ACL injuries or think that you might have an athlete with an injury, please reach out to your athletic trainer. They can give you information and make a plan of care for your athlete. Thank you for watching this session. Please fill out the survey link found on the Bon Secours virtual training page. This will help us improve our videos and present topics that you might be interested in. Thank you.